So very welcome to this special lunch symposium. My name is Mika Salminen. I'm from the Finnish Institute for Health and Welfare. We'll be chairing today. And I'm joined by Outi Kuivasniemi, who is Karvonen. Outi Karvonen. We have several Outis, and I frequently mix the names up. I'm sorry for that. Outi is heavily involved in the work which we will be presenting today, which is actually a joint action funded jointly by the European Commission, DG Sante, and the member states involved. And this is a very wide collaboration over a number of years and very pertinent for what happened the last 3 years. Unfortunately, also we were sort of getting up to speed when the pandemic hit. So this session will be about the SHARP joint action, which is strengthening capacity in preparing for the unexpected. It's basically a health security preparedness session and project, and we will be describing what has been done over these years, which has been quite a challenge because most people who have been working on the project have also been working heavily on their national responses. So I'm quite impressed that actually so much has been done in spite of the very heavy burden that the pandemic caused. So I would invite to us the first speaker, Outi, who will tell you a little bit more about the project, and then after that we will go over to describing some of the work packages of the project. Floor is yours, Outi.
Good afternoon, everybody. Here is the agenda, and then I go to my own slides. Yes, so I'm going to present you some basic information about SHARP joint action, and I will concentrate on those work packages which are not going to be presented today. At first, the abbreviation SHARP, it comes from Strengthened International Health Regulations and Preparedness in the EU. And it aims to strengthen implementation of Decision 1082, and now we have also the new regulation, and then to support the EU-level preparedness and implementation of international health regulations. The expected result is strengthened ability to prevent, detect, and respond to biological outbreaks and chemical contamination and environmental and unknown threats to health. We have 26 associated partners, 35 affiliated entities, which means we have 61 organizations which receive funding from the Commission. And in addition, we have 10 collaborating partners. We started in April 19, or actually in summer 19, and we were able to work only 8 months and then started COVID-19. And you can imagine what it meant as majority of our experts were involved in a national response to COVID. So we had a first amendment for non-cost extension for 1 year, and now we are asking a little bit more. We have 10 work packages. We have the 4 obligatory horizontal work packages. Then we have work package on IHR core capacity strengthening led by Sweden, preparedness and response planning led by Netherlands, laboratory preparedness and responsiveness led by Robert Koch Institute, Germany, and training work package led by Serbia, chemical safety and chemical threats led by UK Health Security Agency, and case management and infection prevention and control preparedness led by Italy. 3 work packages are going to present today, so I will concentrate on the rest of our work packages. First of all, laboratory preparedness and responsiveness, which is led by Robert Koch Institute. It is kind of follower of earlier joint actions, latest of them eMERGE. And they have been conducting external quality assurance exercises on bacteria and viruses, 3 rounds already, and they have organized partner meetings to discuss the results. For task diagnostic approaches, they have assessed diagnostic capabilities. There is continuous SARS-CoV-2 sequencing ongoing, and there are working groups. One of them is on next generation sequencing, led by Netherlands, and basic diagnostics, led by Italy, and antimicrobial susceptibility testing, led by WIM, Germany, and joined by Erasmus, Netherlands. There are trainings organized, and there, of course, due to COVID, there was a long break, but now they are already ongoing, also on site in laboratories. The third task is about laboratory biorisk management, and it is led by Sweden. Work package 9, chemical safety and chemical threats, it's led by UK Health Security Agency. They have completed fact-finding report, which is gap analysis, seeing where countries need to improve in their response to chemical incidents. They have also completed chemical laboratory report about chemical laboratory response network, whether such network would be desired and whether it would be feasible. And the answer was yes. And they have also organized workshops. These have been online. They are going to produce a report on standard operating procedures. Work package 10, which is about case management and infection prevention and control, this has suffered most from the COVID pandemic. It is led by Italy, and Italy was hit worst, especially in the beginning. And all these tasks are not, they are still ongoing. They have not been able to finalize them. But there is going to be this mapping of existing facilities and hospital preparedness for treating high consequence infectious diseases such as Ebola or Lassa or that kind. And they are going to do a feasibility study for expert clinical support service and application of syndrome-based approach. And they did a survey for hospitals concerning COVID in March, but you can imagine that that was the time when hospitals didn't have time to answer to a survey. Some forthcoming events. There is, Sharp is going to be present at ESCAIDE and in National Congress of Physicians in Serbia. Interesting international simulation tabletop exercise is going to take place in Athens, and it will be hybrid, both on site and online, and some workshops coming. And what will be left of all these reports, training, workshops, deliverables, and so on? We have to see how they fit in the new EU health security legislation and the ECDC's new mandate and so on. Luckily, we have a good team of experts working at the Ministry of Solidarity and Health in France, which is looking after sustainability of our work. And work packages have been asked to choose priority outcomes which especially need to be sustained. And one example of those is this EU reference laboratory network called eMERGE. And there are plans to pilot it and especially to take care for its sustainability, and also about these national plans and IHR work and training materials. Our deliverables are available at our website. You are welcome to visit it. And this was my part, and you are always welcome to write to us at Sharp@THL-FI. Thank you.
Thank you, Outi. And as you can see, maybe those of you who have been in this business of international health regulations and preparedness for a longer time, you can see that prior to the pandemic, we built the project quite a lot around that kind of concept. I think there's a lot of lessons that the pandemic have learned and have taught us that has changed some of the thinking. I'll come back to that a bit in the summary part then, but would be good if those of you in the audience who are interested in taking part in the discussion could think a little bit about that, reflect on what we have been doing and what we have learned also about maybe the systems in Europe and what we really need to be prepared for different kinds of emergencies. Thank you. With that, I would thank Outi, and we would go forward in the program. So the first presentation will be about the work package number 5. Numbers don't mean anything, but this is about IHR core capacity strengthening assessment. And we will have 2 speakers jointly presenting this. Dr. Sara Bengtsson from the Preparedness and Crisis Management Unit at the Public Health Agency of Sweden. You will speak first. And then after that, Dr. Mari Nytun-Utheim from the Norwegian Institute of Public Health. Please, the floor is yours.
Thank you, Mika. Sara Bengtsson, Public Health Agency of Sweden. I'm just going to give you an overview of what Work Package 5 is, and then allow Mari to go into detail over the 3rd task on this list. So first of all, we would like to look at building the capacity with the 1082, or now the new regulation, and the IHR. And this has been done with a group of 10 countries. And we have conducted an analysis on what gaps there are to have been strengthened over the joint action, and I've had workshops together to try to promote and catalyze these. Everyone knows that COVID came in the middle, so that first task was more modeled to map out, okay, which capacities did in fact get stronger over the joint action because of COVID, and then discuss those during our workshops, and that task is almost finalized now. Then we have also international collaboration between authorities during the crisis. Again, we're looking at the mapping that was done during COVID, which countries did get help, which countries helped others, and what factors were there to make this go forward. And there will be an expert workshop coming up in February there. Finally, we were looking at after-action reviews and simulation exercises that have been conducted in the past, and looking at how those findings can actually help prepare our core capacities. And with that, I'd like to turn over to Mari, who will be discussing in depth that report and launching it today. Thank you.
Thank you. So my name is Mari Utheim, and I come from the Norwegian Institute of Public Health. So we were responsible for carrying out this task 3. The intended outcome we had was improved use of results from EU-level simulation exercises and after-action reviews, intra-action reviews. These are qualitative assessment tools as opposed to other quantitative assessment tools that exist. So our research questions were, what is currently the added value of these qualitative tools in the IHR monitoring and evaluation framework? What is the output of these tools in the EU? And how can the use of these tools be improved to maximize their added value in this European context? So this work was started in 2019, and when we picked it up again this spring, there was no other way than to also include considering lessons learned from COVID-19. How can qualitative tools contribute to preparedness and response planning? So the data that we included in the study was a total of 17 simulation exercises and 2 intra-action reviews. They were all conducted on an EU level, so no national exercises were included in this study, and they had EU agencies as participants. There were also member states participating, between 4 and 30. And we reviewed a total of 357 recommendations that came from these exercises that were on different hazards: biological, chemical, radioactive. Maybe some of you recognize some of these names of the exercises that were included in the study. We started by structuring a database of all the recommendations So first we classified them by target audience for the recommendations. Some recommendations were clearly to regional agencies in the EU, about 60%, and then other recommendations targeted member states, EEA or Switzerland, who were participating as countries. Some targeted both, and some did not have a target group that could be identified. Then we classified all the recommendations by IHR capacity. And we found that the capacities that were most often assessed were capacity 2 IHR coordination, capacity 7 health emergency management, and capacity 10 risk communication. This is very much in line with other reviews of simulation exercises and similar reports. We did a language analysis of the recommendation to identify recurrent issues in recommendations. So we found some of the most recurrent words, and we used these as search terms to find the most recurrent recommendations. Then we did analysis by target audience, as I showed you in the pie chart. So recommendations to member states were compared to SPAR scores and SPAR indicators to see what else can they tell us than what's already said in the SPAR. For EU agencies, we looked at how recommendations are reflected in 2022's EU agencies' mandates, because these exercises are from a long time period and a lot has happened in the EU over those years. Lastly, we wanted to look at to what extent recommendations overlap with lessons learned from COVID-19. We used the communication to the EU Parliament in June 2021 with 10 lessons learned and compared our recommendations to those. Our results were that 1, simulation exercises and after-action reviews bring out valuable insight in the preparedness and response. They most commonly recommend to improve collection, exchange, and sharing information across borders in the EU and between EU agencies and member states. They recommend implementing coherent, streamlined systems, procedures, and protocols, which makes collaboration across borders easier if you have similar systems on both sides, and to clarify and improve awareness of roles, specifically roles of EU agencies. We also found that looking at 10 lessons learned from COVID-19, 8 of these 10 lessons had been recommended before. Some of them had been recommended quite recently, and some had been recommended 10, 12 years ago. This could mean, 1, that the simulation exercises point out issues that are quite real, that are quite relevant and pertinent. It also means that these gaps that have been identified, they persist in the EU. We've seen that when it comes to implementation of recommendations, a lot has happened during COVID-19. It has prompted and accelerated the implementation of many of these recommendations, but also that EU-level simulation exercises and after-action reviews require follow-up systems in place. They did not have action plans that are recommended to have in this 2018 simulation exercises guideline. So, based on these findings, we had some recommendations that I've summed up in 4 main points. 1 is that after-action reviews and simulation exercises should be used routinely to evaluate functionality of response mechanisms and practice use of them. So one thing is having capacities in place, another is testing how do they function in practice. A lot of participants in these exercises also reported a large learning outcome for them personally. Secondly, results and recommendations should be reported as part of the State of Preparedness report. This is part of dissimulation of the results of these exercises. If people are aware of them, it will be easier to follow them up. Future exercises should include action plans with assigned responsibility for follow-up. Many recommendations are stated as such, but it doesn't say who should implement this? When should they implement this? How will we know when it's been done? That doesn't have to be a part of the report itself, but somewhere in the process it should be done. Then implementation of recommendations should be documented along with the exercises in a centralized exercise repository. If we can know how far we have come, which recommendations have already been implemented, then it will be easier to prioritize the next steps. If recommendations have not been implemented, then that should be part of a conscious decision not to implement it so that it's possible to follow how recommendations have an impact in the EU. Thank you very much.
Thanks very much, Sara. I think we could take questions also. Sorry, Mari. We could take questions if there are any questions at the moment. Yeah, there is one.
My name is Jaap Koot from University Medical Center in Groningen in the Netherlands. I wonder what we have seen, at least in my country, is that despite all the structures, recommendations, procedures that were invented before the outbreak of COVID-19, that they were all put aside because of political pressure, political interference, and panic ruled the response. So to what extent do you take that into account, how political involvement responds to this kind of more technocratical approach in catering for emergencies?
Yeah, I think as you say, during the event, things can get a bit panicked, and I would say that the important part here is to work on these issues in peacetime, not during the events themselves. And that's clearly what our findings show as well, is that the weaknesses in the system can be identified in peacetime, doing an exercise. We don't have to have the real event here in order to find out, is anything working? Are response mechanisms in place and functioning? So I think the important take-home message here is, if we can improve implementation of these recommendations during peacetime, then we have prepared a lot better for the event itself. When everyone is panicked and everything seems a bit chaotic, it's easier to come back to something that is already implemented and rehearsed. Yeah, thank you.
Thanks, Sandy. If I may add to that, while you can set up the next presentation. This is a very pertinent question, and of course, very obvious one of the. That's why I asked the audience to think a little bit and reflect about the sort of pre-planning and then what actually happened during the pandemic. There is no good answer to that, because the plans are done technocratically from a technical level, and they have taken into account a scenario where there is a sort of systematic approach. However, the pandemic was not just a health issue. It was a comprehensive societal crisis. And in that kind of situation, there's no way that just one sector actually will be running the show. And I think that's something we have to accept. But I would certainly support what was said, that it's still useful to plan, even if things go slightly differently than in real life. Thanks. So we go forward to the next presentation. It will be about strengthening preparedness and response planning. And this presentation, which is also one of the work packages described, will be given by Dr. Betty Fordrow from the RIVM.
Thank you very much for introducing. And I think that one of the things that has been discussed in the previous, following the previous question, is something that we address, I think, partly at least in the work package 6, which is about multi-sectoral collaboration during public health emergencies within SHARP. Okay, within SHARP, we are responsible for what I said, preparedness and response planning, and that's meant to support the EU member states and joint action partners, countries in developing operational intersectoral preparedness and response plans for serious cross-border health threats within integrated all hazards approach, which is quite a lot of words, but it's important. So what's the problem? And I think that it has already been said just now, that state parties have made efforts to encourage sectors other than health to contribute to assessments, planning and interventions aimed at strengthening preparedness and response capacities under IHR, which was already mentioned in Work Package 5. But nevertheless, the effective multi-sectoral collaboration remains a challenge in most, and if not all countries, and we all experienced that in the last COVID-19 pandemic. And one of the barriers that we looked at was that it appeared that there appeared to be a lack of clarity on which sectors have to be involved at the various stages in the response cycle and also in the preparedness cycle. So what did we do when we started off with Work Package 6, which was just prior to with a systematic review, and we planned there to identify the broad sectors mentioned most frequently in peer-reviewed literature and on public health emergency preparedness and response. And we, while at that time the pandemic started off, we decided not to include the COVID-19 pandemic, but have the cutoff of the systematic review prior to the pandemic. So it went until the end of 2019. And we identified and grouped organizations mentioned in the articles into sectors using an amended list based on the European Commission's list of sectors and economic activities. And there we came up to a total of 28 sectors that were involved. And if you're interested in it, the review was recently accepted by BMG Open and will be published soon. So check if you can check that, it's written by Sandra Kamga as first author. So what did we find? What's not really unexpected is that the most important sectors involved were governmental institutions, human health, experts, and civil society. They were mentioned in all these, and also at the different phases most frequently, but that doesn't mean that other sectors were not important or should not be involved. So the next challenge for us was to establish what key sectors should be included according to national experts. And that's what we did subsequently. We started off with the surveys within the partner countries and using the same 28 sectors in the systematic review. And when we surveyed those professionals on all hazards risks, their expert judgment was then successively collated via an initial questionnaire and a hybrid meeting. And in that hybrid meeting, we did a random-modified consensus procedure to adopt a consensus on different additional sectors that should be involved. And after that consensus meeting took part in September this year, so 2 months ago. And after that, we had a second questionnaire to crystallize a judgment on these sectors. And what we saw, what came out of the surveys and the questionnaires, and most importantly on the consensus meeting, was that in addition to those 4 sectors that were already reported, there were 6 additional sectors that were reported to be important, particularly in the preparedness part, but also response and recovery part, and that included agriculture, forestry, fishery, and the environment, the ICT service activities, the human transport and points of entry, education and trainings, and we'll come to that in Work Package 8, and this was of course also in Work Package 5. Energy and water supply was considered very important, and sewage and waste management, particularly around all the care in hospitals, for example, and also media and communication were considered very important. In addition, veterinary activities were also considered important, and chemical industry should not be forgotten, particularly when it considers therapeutics and pharmaceutical companies, but also, for example, for diagnostics. We all recollect the problems we had in the beginning with PCRs, and also personal service, administrative support, and security and investigations activities. The questions that we raised, that we still have raised during this research is, and we still want to address in the coming year, is our amended list based on the European Commission's list of sectors and economic activities suitable for preparedness and planning, or must an alternative be, yes, I'll finish, and I will manage easily. Are the sectors as they are stated not too broad? How to deal with the fact that roles and tasks of sectors have inconsistent national and subnational settings and context? And an important thing is, should one focus less on identifying sectors that need to be involved and more on roles that need to be played? This may make it easier to identify which organizations or sectors is more suitable and in a specific national or subnational context. So, to finish off, and we plan to do these things, and we really could could benefit of your help. So if you are interested, please help us answer these questions. And the first one is, send us your current national public health emergency preparedness and response plan, all hazards or for any other origin threats, or send us the subnational public health emergency preparedness and response plans. These plans may be in your own national language. They're very good translation tools. And please send them then to us at the following emails. That's sharp@rivm.nl until the 30th of December. And of course, if some bit later, it's not a problem at all. What will we do with it? We will compare your plans with existing other European public health emergency plans. We will try to identify common roles in public health emergencies and work towards developing a new categorization of roles and sectors in public health preparedness and response planning. And then share, of course, your findings with you to help improve your future planning as well. So, thank you very much. And if there are any questions, I'll take them now or later if needed.
Yeah, thank you very much. Thank you very much. If you stay there, Bette, and I would invite for questions to these presentations. I have some at least, so, but I don't see any in the audience at the moment. So maybe a reflection. I was when you showed the first sort of part of your overview of the literature and media was 2%. I was quite surprised, but then you mentioned actually that in the second part it was perceived very important, and anybody who was involved in the pandemic knows how significant the media coverage was and how it also had both good but also quite negative effects. And I'm talking about media in a very broad sense, not just traditional media, but all the different kinds of social media platforms that we are using these days. We can't escape that anymore, and I think we need lots of new strategies to try to work with or around or towards those, if we will be able to sort of maintain trust in that the system is actually working despite all the false news and conspiracy theories that run around in this area. So that was just a reflection. So I think we should go forward and take the next one. Thank you very much, Betty. So the next speaker will be Dr. Janina Schäfer. She will talk about strengthening IHR implementation through cross-sectoral trainings. And that's one of the lessons of the pandemic, is that since this was not just a health emergency, even though the cause cause of the emergency was a health problem. Most sectors had to be involved at a certain stage. So that's why it's great to hear about this from Janina. The floor is yours.
Yeah, thank you so much for the kind introduction and of course for the opportunity to speak today about the trainings we conducted under Work Package 8 in order to strengthen capacity related to IHR in the public health workforce. So one of the main tasks in Work Package 8 was to develop basic trainings on the IHR as well as some advanced trainings on certain aspects of the IHR. And I'm going to start with the basic training. So as so many other things, this was initially planned as an on-site training, but due to the pandemic, we had to reconceptualize the training and adapt it to an online context. And we did so by dividing the training content into 5 modules, which I'm going into a little bit more detail about later, with the overarching aim of providing basic IHR knowledge for personnel working in different sectors and positions relevant to the IHR core capacities. So our target audience were public health professionals, most of them junior or mid-career from different sectors. And as there is already so much material available from ECDC and WHO on the topic, we of course incorporate that in our trainings and build upon that. And we were very lucky also to have facilitators from WHO Euro joining us for the trainings and really providing their unique perspective and addressing questions. So before we have a closer look at the content, I just want to emphasize that we not only aimed at conveying pure content, but also really providing an opportunity for collegial exchange and exchange of experiences and good practices, since this so often fell short during the pandemic. And to do so, we had in all modules quite a lot of breakout sessions for people to really get the opportunity to discuss and get to know each other better and network. But also we applied quite a lot of interactive online tools with whiteboard, polling, quiz, or word cloud functions to really make it interactive and get the most of the training. So content-wise, the module 1 provided an introduction to the IHR by explaining the history and how past pandemics or health threats have shaped this legal framework as we know it today, and introduced the IHR core capacities and functions to build upon in the later modules. The second module then focused on detection, assessment, and communication under the IHR and introduced the concept of public health emergencies of international concern, and very much focused also on the notification assessment tool provided in Annex 2 of the IHR to help countries decide which cross-border health threats they want to notify WHO about and how to decide that. And to give a little hands-on practice on that, we developed certain short scenarios which the participants then could try out in breakout groups assisted by a facilitator from WHO or RKI. In the third module, we already heard from Betty how important intersectoral collaboration and coordination is. And we, in addition to the theoretical frameworks and contents, we here implied 2 larger case studies where participants could really practice this line of thinking and think about how they would then convey that to their specific contents on their specific needs. The fourth module then gave an introduction to risk communication and community engagement. And here again, there was ample opportunity for the participants to try out certain aspects of that. And the last module then focused on the IHR monitoring and evaluation framework, so the States Party annual reporting as the mandatory component, as well as the interaction reviews, simulation exercises, and joint external evaluations. So that was the basic training in a nutshell, and now I'm going to move on. Just a quick wrap up. So we have conducted this training cycle 4 times so far, the first ones in 2020 and 2021. But as you can see, due to the pandemic, there was quite a lot of staff turnover there. So we had 60 people completing at least one of the modules and about 45 people completing all 5 modules in the first circles. And then for circle 3 and 4, we had 32 people from 14 European countries who completed the whole course. Moving on to the advanced trainings. I just want to emphasize again that Work Package 8 wasn't the only work package that developed trainings, as we already heard from Uti. For example, the laboratory work package, as well as the work package focusing on chemical hazards, developed some trainings as well. But here I'm going to focus on the trainings developed under the auspices of Work Package 8. And as you can see here, we pretty much focused on trainings on interaction reviews and simulation exercises, as you already heard from Mari, how important those tools are in actually being better prepared for coming crises. And again, there's a lot of resources available from ECDC and WHO, which is why we were very glad that we also had facilitation support from both organizations for those trainings, who could really move the workshop even further and address imminent questions. And all training materials, also for the IHR basic training, are already or will soon be available on a training platform, Work Package 8, delivered for SHARP members for this specific content, so that the training materials are also sustainably available for the joint action partners. So one example of the advanced trainings we conducted was a workshop on intra and after action reviews that we conducted in June this year. And as Mari already said, IARs and AARs really provide an opportunity for collaborative learning to help improve responses to current crises and health threats. And here we really aimed for an interactive setup. So we asked participants to do a preparatory e-learning, either from ECDC or WHO, that are available online free of charge. And after that, participants alone or in small groups developed a concept for an IAR in their country or for their specific area of work to really meet their needs and their respective priorities. And the main part of the workshop was then actually a peer review session where the participants presented their content to the other groups and received feedback from the other groups, as well as expert facilitators from ECDC, WHO, or the RKI. And participants really told us how beneficial this process was for them, not just in order to better their concepts, but also in planning the way forward. And as a last example, just in September, we conducted a workshop as an introduction to simulation exercises aimed at providing an overview on benefits, scopes, types, methods, and steps of those simulation exercises. And here again, we really put much emphasis on giving the opportunity to try out certain aspects of analyzing and planning simulation exercise concepts. And here again, we had also colleagues from WHO Euro and headquarters, as well as ECD, joining the call, who presented on their tools and resources and how to use them in order to drive this forward. And all trainings have been evaluated by an online survey that was kindly set up by Work Package 3. And all the trainings were evaluated very positively. So the basic training included, with an average overall satisfaction of 95 out of a possible 100 points. And in particular, the content, the organization, and the interactivity of the training were rated very favorably. And moving on, we're currently in the process of planning a training on recovery after crises, and more information on that is going to follow soon. So with that being said, I conclude and thank you for your attention.
Thank you very much. When we started the work, I think very few people were aware, actually, outside the very sort of select enlightened that have worked on the IHR and cross-country preparedness in the past were aware of the IHR even, and so the work that you're doing is important in that regard too. We have gone through the actual program here, and I would like to see if there's anyone who either would like to ask a question for the last presenter or raise some questions based on what I said in the beginning, or any other thing that you would like to bring up. Yes, there is the gentleman there.
Yeah, thank you for the opportunity to ask a second question. Of course, COVID-19 has been a major event in Europe, but globally we have had Ebola, Zika, chikungunya, dengue, many other important public health outbreaks. To what extent have you been able to draw lessons learned from those outbreaks, and for example, in terms of preparation and training, use experiences from how the outbreaks in other continents were addressed? Thank you.
Thanks. I think I can probably try to address that. I think the fact that this joint action exists is kind of a follow-up on those experiences, because what we know is that if you talk about the international health regulations, they were agreed on in 2007, and by 2012 the common agreement was that every country should have established those core capacities so that they would be prepared for various health emergencies. Now, we all know that that didn't happen, and was reflected partly in several events after that. At least we thought so. But certainly the ability to tackle localized outbreaks and quite severe outbreaks also was not equally distributed among the countries of the world, not even among the sort of places where quite high risks exist. So for the European Union, we know that there are some health disparities in this region too. And I think the Commission's aim with putting funding and seeking partners in this was trying to address this question. We were slightly late because it would have been great to have this project maybe 3 years before, to be honest. Having said that, I have to say that the capacities which are in the IHR do not address the problems we had with coping with the pandemic. They are more preventive in their sort of scope. They work for smaller issues. There's a good correlation between the sort of scoring that you get from the SPAR, which is the WHO's instrument for assessing capacity, and basic things like childhood mortality, communicable disease burden, pre-COVID. That correlation is good and strong. There is absolutely no correlation with hard outcomes in the pandemic, which just shows that it measures something else. And that is the thinking that we have to do, I think, for the future, because what we could not cope to a level that maybe the expectation was with the global pandemic, even in Europe. Our health systems were not prepared for that, which is in a way understandable. They are prepared for mostly chronic type of diseases, and infectious diseases are a much more minor issue. And when you have a pandemic, those capacities which would be needed just aren't there in that level that you would need. That would go for most countries in Europe, I think. So we had to scramble a lot and learn a lot, and we did a lot of things which we actually don't know yet if they were actually effective. That is the reality also. So I think there's a long learning process that we have to go. I was in a different seminar earlier on, and the sad fact is that many of the measures which were taken, there was very little research while we were doing those things. And post-assessment is going to be much more difficult. We had the opportunity to maybe study those, but because of the various pressures and also the political pressures to do something, it was almost impossible to do them. So that's a little bit pessimistic, but I think humanity as a whole, anyway, will learn from every experience. So I think we can learn from the pandemic also and strengthen our systems so that we will be more, people use the word resilient. I think it's a little bit overused. It's maybe more that we have to be able to scale functions when something is overwhelmingly growing, which we don't usually deal with. Okay, any other comments? If not, then I think we are also by the end of our time. Can we get the final slide? You can find us on the web. Google is a good tool. So thank you very much for the attention, and have a good conference. And thank you for all the speakers.